Okay. Assalamu alaikum, everybody. A very important meeting today called COVID and the effect of COVID in Pakistan. We have three very good talk. We have one from Professor Brigadier Sohail Amin Saab, who is the trauma lead of Pakistan and the lead for the Army medical schools and various army activities. Shah Saab, KM Shah Saab is here. He is our arthroscopy lead, and Masood Umar Saab is here, who is going to be moderating the whole show, and he's also running the show for the Orthocon, which I'm very grateful for him to put the banner on this. I will just tell you the panel, and then I'll hand it over to Masood Saab and see where he wants to go from there. So the panel includes KK Saab. Apparently, he's going to join us later. We also have on the panel Amir Aziz Saab, which we can see, and we also have Arif Saab, Shahid Dubai, Zaid Askar Saab. Welcome, Zaid Askar Saab. I sort of missed you in the middle here. We're hoping for Brigadier Khalid Masood, he's now no longer a colonel, he's a brigadier, to join us. Shahzad Sadiq is here, Amir Kresh is here, Tariq is here, Rian is here, and Kazim is here. And we're waiting for Jamali and Sufyan to join us. So over to you, Masood.
Shukriya, sir. Thank you. Bismillah ar-Rahman ar-Rahim. Inna a'tainaka al-Kawsar fasalli li rabbika wanhar inna shaniyaka huwal abtar. Allahumma salli ala Sayyidina Maulana Muhammadin wa alihi barik wa sallim alayh. Thank you for giving me this opportunity. So far from the platform of Orthocon, this will be our 8th webinar that we are conducting. Or by all means, this was the most political webinar that I had to fight through. Anyhow, without going into the background, wo baad mein discuss kar lenge. We should start. We are already 7 minutes late. To begin with, we have Dr. Sohail Amin, our great colleague from Army. He will be talking about trauma issues and with the basic theme of new normal in COVID times. So over to you, Sohail Saab.
Thank you very much, Masood. Now let me start by expressing my gratitude to the organizers of this webinar, particularly Mr. Munawwar Shah from Walsall, UK, who actually made this the effort for gathering us all, and also Dr. Masood Umar for having, sorry, I'm trying to actually share my screen first.
Please, बाकी सब लोग अपने mic mute कर लें, तो आवाज सबको clear आएगी.
Can I share my screen? I'm not able to share the screen actually.
Now at the bottom of your should say share screen at the bottom of your.
But you have to enable me rather.
Yeah, you're absolutely correct. Yeah. You're absolutely correct, sir. I have this thing. I'm not sure where to do that, so I'm trying to be.
Because the message shows host has disabled the share screen.
So can you try now again, sir?
Yeah. Can you see the screen now?
Not yet, sir.
अभी नहीं आ रही.
I'll try again.
Yes, it is coming.
आ गई.
It is now.
अब देखें, अब ठीक है?
Yes, sir.
Fine. So
उसको full screen कर.
Full कर दिया जी. Is it okay now?
Yes, sir.
बिल्कुल.
Fine. So my gratitude to you, Mr. Munawwar Shah and Dr. Masood Umar from Khan for having me on board to talk on trauma amid this COVID-19, a Pakistani perspective, of course. And of course, it's more of a perspective from a military side, because I work over here where it's just a pure military setup. Now, we all know that human civilization has seen many calamities throughout the course of history. And we had share of plague, pandemics, we had world wars, hurricanes, earthquakes, what and what not. But this pandemic has affected human life on such a global scale and with such a ferocious speed that we are virtually paralyzed. Although this novel coronavirus is just like a flu-like illness causing respiratory problems, but it is potentially fatal, and we see that how much devastation it has already caused. And this fraction of a micron virus has virtually brought our world to a standstill. On one side, we had seen empty streets, desolate highways, forsaken marketplaces, deserted schools and offices, homes virtually turned into quarantines. And on the other hand, the social distancing, masked humans, and sanitizing of the hands has become a new way of life to us. And this way of life has actually been thrust upon us now. Now, in Pakistan, the first case of novel coronavirus was actually linked to returning of pilgrims from Iran. And the first case was reported on 26th of February, 2020. And in a matter of days, this pandemic, it spread to all the 4 provinces of Pakistan. And the first death was recorded on 18th of March. Now, as the positive cases, they surpassed the figure of 1,000 around late March. There were closure of borders and international flights were also closed. There was nationwide lockdown, which was imposed on 25th of March, 2020. And we have seen that month of June marked the highest number of the cases, and the tally actually reached around 200,000. And death toll by 30th June was around 4,000. And if I share the snapshot of this COVID-19 dashboard of government of Pakistan today, it shows that there are around 2,63,000 cases, confirmed cases, and around 5,568 deaths that have been reported to date. Now coming to our setup, I work in a military setup. So in Rawalpindi, the military has got 2 tertiary care hospitals, which are large hospitals. One is known as Pakistan Emirates Military Hospital, and the other one is Combined Military Hospital. Both are tertiary care teaching hospitals, and we have combined bed capacity of around 2,200. And in this orthopedic department has around 150 beds. We have 4 orthopedic units, 3 in CMH Rawalpindi, 1 in MH Rawalpindi. And there is large influx of course, entitled population, and total entitled population that we actually cater for is around 10 million. Now, accident and emergency department of our hospitals are very busy. Usually, you can see that we have a dedicated trauma center as well. And despite this COVID-19, in first half of 2020, there were more than 25,000 entries to the trauma center. And of course, if we break down, then from these entries, we would find that extremity trauma actually makes up a significant proportion. Now, once the COVID-19 set in, we had many local challenges. We had insufficient ICU care as far as number of beds was concerned. There was shortage of ventilators initially and personal protective equipment. And we needed to reorganize the health structure totally because we needed to protect the patients as well as the healthcare workers. And at the same time, we had the challenge of continuing our emergency services. So in military, everything happens through hierarchy. So at the highest level of military our medical directorate at GHU, there was few decisions that were taken to reorganize and restructure the services. And what they decided was that one of the hospitals, that is Pakistan Emirates Military Hospital, which is around 1,100 bed hospital, was totally devoted to the care of COVID-19 patients. It was vacated, and it was thought that all COVID positive patients would be nursed in military hospital, along with a sister facility of Armed Forces Institute of Rehab Medicine, which has around 500 beds. This was made into a quarantine facility. And Combined Military Hospital Rawalpindi, where I work, was made a COVID-19 negative sort of a facility, and all patients who initially reported as emergencies had to report at CMH, and they had to undergo all the tests. And if they were positive, they were immediately shifted to from the suspect area of the Combined Military Hospital Rawalpindi to the MH. And if they were found negative, then they would be given definitive treatment and further treatment at CMH Rawalpindi. So there was also high-level decisions to have resource management, and they included, of course, closure of all outpatients in the first phase. And we were told to abandon and postpone all elective surgeries till further orders. And human resource had also to be optimized and to reduce the physical presence. And at some points, remote working was implemented where it was possible to do so. Now, coming to the clinical pathway, in CMH Rawalpindi, since this was the hospital where all patients were directed to report initially, there was initial screening of the patients. And if the patients were screened for temperatures, that is, if they had any fever, or they had a travel history or some history of contact, then straight away they were put into an area which was known as COVID suspect area. And if they had no history and their temperatures were normal, but they had some medical and surgical emergencies, they were nursed straightly to an area which was known as acute and surgical/medical unit. So in these two screening areas, I would say, or COVID suspect areas, first they were taken through two tests, which were PCR for COVID-19 and HRCT test. These two tests were considered mandatory. And once both of these two investigations were reported within 8 to 10 hours, it was decided whether this patient is going to stay in CMH, or if found positive, in any case, would be sent straight to the MH without going further into the hospital. So this was how we actually started off. We made these as the initial pathway for the patients. And all COVID-19 patients, as soon as they were tested positive, were shifted to MH. There we had dedicated teams, dedicated wards, ICUs, and operation theaters. The staff already had undergone some training, specific training for donning, doffing, and nursing of COVID-19 patients. Or stable and symptomless patients were quarantined in AFIRM, as I told you, a sister organization where, which is just close by to the MH, and it has around 500 beds. So they were kept in AFIRM till the time their PCR tested negative, and then they were discharged. We had to undertake few procedures as well, essential procedures in COVID positive patients. We had a dedicated orthopedic team working in MH, and mostly these surgeries quantified to damage control. And initially, as there was the classification of aerosol generating procedures was evolving, and we thought that use of power tools would be vulnerable to make vulnerable for spread of the disease. So minimal usage of power tools was done initially, but then gradually as the classification evolved and we came to know that these procedures are not directly classified into AGPs. So gradually we started using few power tools in these patients as well. In CMH at our site, where all initial emergencies came, and once the tests were done, that is PCR testing for COVID and mandatory HRCT was done in the COVID suspect area. So after these two tests were negative, then only the patient was admitted into the ward, specific wards for different patients. But if in any case HRCT was reported to be, test was reported to be indeterminate, then we actually repeated the COVID PCR for COVID within 48 hours, and also got and sought opinion of the pulmonologist. So if he thought that, this is, and the COVID test came, two consecutive COVIDs were negative, PCRs were negative, and pulmonologist review was clear, then only the patient was admitted into CMH. We also actually devised a COVID-19 consent form, informed consent for patients who had COVID-19, because we thought that the patient need to give us COVID-19 high-risk consent even if we are operating them in emergencies. And if you see, this is the form that we devised, and the salient feature was that we had mentioned in this form that in case the patient contracts COVID-19 in the perioperative period, the mortality would be slightly higher. It would be around 10 times more than what it is in normal circumstances. So we thought that this information has to be given to the patients, whether we are operating them in emergency, and we got this COVID-19 high-risk consent form signed by all the patients. Now, it is apt to mention over here that in the military setups, the setup at Rawalpindi actually holds a central position, and all the policy making for all military hospitals all around the country is done through Rawalpindi, that is the headquarters. So we made few policies, protocols, SOPs, and they were disseminated to the network of all the military hospitals, which are around 40 in the country. So we had to do this priority stratification for orthopedic procedures, and we made and divided these procedures into 5 groups. We took guide from the guidelines of the Royal College of Surgeons, obviously, and currently we are performing surgery on priority 1 to priority 3 patients. And lately we have started doing and giving care to priority 4 patients as well, which mainly, as we are going to see in the ensuing slide, belong to the sarcoma group of patients. So priority 1 was basically emergent surgery, which required intervention within 24 hours, mainly consisted of dislocations, acute compartment syndrome, open fractures, fractures with neurovascular compromise, and infective joints, of course. Priority 2 were urgent patients, which required intervention within 72 hours. And these mainly consisted of intra-articular fractures, unstable pelvic fractures, or lower limb long bone fractures, hip fractures, pathological fractures. Priority 3 was urgent elective, requiring intervention in 2 to 4 weeks' time. And we included upper limb fractures mainly in this group, along with acetabular fractures and tendon injuries and lock joints. Priority 4, which we have started lately, I think for the last 2 to 3 weeks, we have started doing some of the tumor cases. These are MDT-directed sarcomas, which were actually waiting, who have completed their neoadjuvants, and they were waiting for the surgery. So now we have started putting these patients into lists, into our operating list as well. And we have started performing surgeries on these cases. And the last is priority 5, of course, which is non-essential elective, which we can actually still postpone, and we have not started yet off with these surgeries, which mainly is the reconstructive surgery of joints and bones. Now, just taking a look down to our workload during these 3 months. So in CMH Rawalpindi, we had around 260 admissions from 25th March to 30th June 2020. And these were all mostly orthopedic trauma that we needed to do something about. And out of these 260 admissions, 35 patients, that makes around 13%, they tested positive for COVID-19. And out of these 35, we had to operate upon and do some kind of damage control surgery in 14 cases, which were operated in a military hospital. We had a dedicated team over there, which operated with full precautions on these 14 cases. The remaining 225 patients were managed in the main operation theaters of CMH Rawalpindi. And if we just see the surgical load, we can see that the road traffic accidents and high energy trauma made around 42% of the cases. And geriatric fractures is the other group that was major, and it constituted around 33% of the cases. Rest 18% were pediatric fractures, and urgent essential electives that we have lately started, along with some upper limb fractures, made around 7% of the surgical workload. Breaking it down further, what were the types and kinds of fractures that we did? The largest group was, of course, hip fractures, which made around 24%, followed by tibial fractures, which was 16%, followed by femoral fractures, around 14%. Another significant group was pediatric supracondylar fracture, which were around 10% of the cases. So this was the breakdown if we see what kind of fractures we had to operate during these 3 months. Now this is interesting. This I've tried to make just the comparison in trends in trauma presentation within the same period, April to June, last year, that is 2019, and this year, 2020, in COVID-19. So if we actually see through this slide, we can see that in the case of road traffic accidents and high energy trauma, we see that there was a reduction in cases, around 50% reduction in the number of cases. Similarly, in total trauma surgeries, if we compare the numbers, it is around 30% reduction that we have observed in the number of cases. And as we do expect that these two groups, that is geriatric fractures and pediatric fractures, there was very little reduction in the number of cases, and they were almost similar, but rather we could actually ascribe this to people having a fear of coming and reporting to doctors as well, and coming to the hospitals during this period as well. So coming to the end of my presentation, I would say that there is some good always that comes out of the worst. So there is a silver lining to this COVID-19 as well. We have coped the challenges, we have embraced the opportunities, and we have attained many new normals. So if we see that in our hospital now, telemedicine is a routine. We have remote online clinics, which were not there previously. We have appointment-based clinics. We have evolved all the system where there are physical encounters with all precautions. We have made special clinics for that. And also we have started doorstep delivery of regular medication for all chronic ailments, chronically ill patients. And we have launched this new system of telepharmacy also in our hospitals. I would say that this experience, first-hand experience that we had in this dealing with COVID-19 has actually, through digitization, automation, and optimization of processes, has actually led us to find and lay the foundations for new healthcare delivery. And we are actually observing a paradigm shift in delivery of healthcare services in Pakistan. And I believe and I am sure that these changes have come there to stay now. And of course, if they stay, our healthcare delivery certainly is going to improve. So this is the silver lining of this COVID-19, that some good at least has come out of this worst situation that we had been in. So to conclude, I would just say that, of course, management of injured population during this current pandemic has posed many challenges to us. And we do expect that disabilities from all these trauma cases will again pose challenges in the post-COVID-19 phase to us as well. And we will also face the challenge of coping with the backlog of postponed elective cases once this pandemic is over. So these are the challenges that we are going to face in near future. And I hope with our convictions and with our determination, we are going to deal with these challenges aptly and appropriately. So with these words, I would end my presentation. Thank you very much. This was my perspective, working in my own setup and how we actually worked through these 3 months of COVID-19 pandemic. So thank you very much. I'm again grateful to the organizers for giving me this time. And if you have any interesting comments to make or any suggestions, I will be more than pleased to welcome them. Thank you very much.
Thank you, Sohail Bhai. I think if everybody agrees, we can take comments and questions at the end and let the presentations flow in a sequential manner. So next in line is our colleague, chair of the Arthroscopy Forum, Dr. Khalid Mahmood Shah. We will be talking about sports injuries and their management in this COVID era. Over to Dr. Khalid.
I suggest, Masood Saab, that everybody writes their question on a piece of paper before they forget them, because by the end of the talks, we would maybe be confused or lost in thought process. But yes.
Thank you
आपकी आवाज नहीं आई
very
अनवर भाई।
much, Dr. Masood. Uh, मेरी नहीं आई है, मनोहर साहब की नहीं आई।
आपकी आ रही है लेकिन बहुत रुक रुक के आ रही है।
Is it better now?
जी बेटर।
Okay. Thank you very much for giving me the opportunity to talk about sports surgery amid COVID-19. I'm grateful to Manawar Shah, who took the trouble of organizing this webinar. And I would stress on trouble. And I'm sorry for all that he had to go through. But results are there. We are organizing it, and I'm sure we would benefit from it. And we have a very good panel of experts to also give their opinion. I would be talking about the surgery. Sohail Amin has very complex. Sorry, what you say?
फुल स्क्रीन कर लें आप स्लाइड शो पे।
Full screen.
Thank you.
Okay. Sorry. So here, is it better now?
जी सर, थैंक यू।
Okay. Sohail Amin has aspects regarding emergency procedures. I would focus myself on the elective side, and as I was going through the literature review, I came across a very good presentation regarding the consensus statement of American Academy of Orthopaedic Surgery on resumption of elective surgery amid COVID-19 pandemic. I feel that this is a very comprehensive guideline and would focus my presentation based on these guideline and its comparison to our setup and ground realities in Pakistan amid all the resource constraints. I also feel we have started using these guidelines in our setup, that the majority of recommendations are easily doable in Pakistan without any major outlay of funds. The first question to be asked these days is, when will SARS-CoV-19 pandemic end? The answer to it is no one really knows. But there are certain factors that would ultimately lead to eradication of this problem. The first one being herd immunity. And this will take some time, basically meaning that the majority of the population gets infected and the virus does not have any more people to infect, so the infection dies down. The other thing that could happen is that the virus mutates to a less virulent form, or we are able to find a drug therapy which treats this infection. And lastly, the viral vaccine is produced in the coming future. But till all these factors are there, we have to live in a new normal situation. So then the question to ask is, when to resume surgical procedures? The first aspect would be that the government issues a decree which lifts the lockdown in the cities and the country, which signals that the infection is under control. But in order to do that, they need a consistent decline in the cases. According to the numbers in Pakistan, this is already happening. Maybe we could have different views on that. But as per the official data, the numbers are decreasing. So probably we could undergo and start our resume our elective procedures. But the other aspect would be that in order to do that, the hospital should have capacity available, which is separate from that designated for COVID-19 patients, because you will still have these COVID-19 patients coming to the hospital for procedures, and they have to be managed in a particular manner. Then the issue would be that should the patients with the active COVID-19 undergo elective surgery? The answer would be no. As long as a patient has the classical symptoms of fever, cough, and shortness of breath, the elective surgery should be delayed, and the recommended quarantine period is 14 days. And after that, the patient should again be assessed for the symptoms of fever, cough, and shortness of breath. And if it's not there, they could be scheduled for surgery. What should be the preoperative considerations? In the outpatient clinic, when there is an indication for sports surgery, the usual pre-op test should be carried out. But along with that, COVID-19 screening is important, as was discussed by Professor Sohail Amin. COVID-19 tests are mandatory. Once all these are in line, then we could have the patient admitted. But during the period from their clinic assessment to admission, they should also be educated as to COVID-19 precautions, such as washing of hands, physical distancing, use of mask, etc. All the patients that enter the hospital, they should be advised to wear the mask at all times. This is not only for their own protection, but also for the protection of the people around them, because there are a number of asymptomatic carriers also. As to the screening for COVID-19 symptoms, a risk assessment questionnaire should be used. We already know that there are high frequency of symptoms such as fever, cough, and fatigue in these patients. And anybody who gives these symptoms in their history should be evaluated further with proper testing. The issue would be that should all patients undergo elective surgery be tested? As mentioned earlier by Sohail, yes, in high prevalence area where you have a large number of COVID positive population, there the testing should be mandatory. Whereas in low prevalence area, it should be based on the assessment made with the questionnaire and the symptoms. Because these tests are expensive, and in our surroundings, we have to be mindful of.
सब लोग अपने mic off कर लें, please. Only Shah Sahab is allowed to have an open mic. Thank you.
Okay. Okay. So, in order to decrease the cost of treatment, these assessments should be based on a proper questionnaire and symptoms. The tests to be carried out were mentioned earlier is the reverse transcriptase PCR testing, and the data has shown that the probability of detection by PCR is about 80% or more during the day 3 to day 10 of the infection, and it correspondingly starts to decrease because the formation of antibody leads to the decrease in the viral load of the patient, thus affecting the testing. The other test to be used is antibody testing. It is still a bit controversial because the kits being used for antibody testing are not standardized and the results could vary. But it would be a useful adjunct because during the healing phase of the infection, the antibody IgG starts to increase from day 7 onwards. And if you have that detected, it is at least a sign that the patient is responding and is in a healing phase. So coming to the considerations as far as the operation theaters are concerned for COVID-19 surgeries, it would be advisable and recommended that the operation theater ventilation system should be such that it has 20 air changes per hour so that the chances of airborne virus are minimized. The number of equipments in the theater should be reduced. HEPA filters for filtering of the ventilation is advisable. The positive pressure would be another advantage. Then minimizing the number of people inside the operation room would be recommended. The other thing that would be very useful is the ultraviolet C light for disinfecting the OT. The only disadvantage is that it is harmful to the skin and eyes, so it cannot be used with the personnel in the operation theater, and it should be used once the theater is locked down. As to the protective equipment during surgery, it is preferable to use disposable surgical suits, N95 respirator, or sometimes a double surgical mask if the N95 respirator is not readily available would be an alternative. Goggles or face shield to protect the T-zone, that is the eye, nose, and the mouth area where the virus infects through the mucous membrane. Patient should also wear mask, and the positive ventilation is recommended. What other precautions to be taken by the operative staff is to minimize the number of people going in or out of the theater, reduce the door opening, minimize aerosol production, the procedures such as electrocautery, burr, or drilling, and also to minimize the equipment as surfaces which will provide the place for the virus to rest. As to the operating theater cleaning, wiping a surface with antiseptic solution is advisable as frequently as possible. Again, ultraviolet C lights at the end of the day would be beneficial. A mobile light like this one shown here are more useful because they can be moved from area to area, and their control is outside the theater, and it could be switched on and off from there. Once the surgery is done, in the recovery room, the distance of staff and patients should be at least 2 meters. Again, N95 mask and PPEs are to be worn by the staff and the patient also. The principle of avoiding overcrowding should be followed. Clean surfaces and the use of UVC is recommended here also. These are all simple things that could be easily done in our circumstances, and we have been practicing it and feel that this is quite quite useful. Post-op protocol, the patient should be discharged as early as feasible to his home surrounding. Um, Telehealth, where appropriate, instead of clinic visit would be beneficial. And also online rehabilitation if necessary technology is there. If that is not the case, then the patient should be advised as to the necessary rehabilitation exercises at the time of discharge. Thank you very much. I feel that these recommendations are possible in Pakistan, and because the elective surgery would be practiced quite frequently now in Pakistan also. So we should make an effort to follow these. Thank you very much.
Thank you, Shahzab. Continuing on the same line, I would just take you through the new normal of elective surgeries and the changes we have done in our setup, which is a private university setup. Nagar Sahab, मेरी screen नजर आ रही है?
जी आ रही है.
Yes, we can see it, sir.
All right, sir. Bismillahirrahmanirrahim. So I think today's webinar, before I start, today's webinar is a unique combination of local experience as well as international experience. Obviously, that's why I'm sparing the later half for a very mature discussion and guidance to us who live in this part of the world where resources are limited. But actually, the virus also did not hit us that badly as it did in UK, and where there are significant differences in public and private hospital setup and management. So I would take you through in the next 10 minutes or so the changes that our hospital incurred during these times. And that's what a small level private university hospital could undertake. And were there any benefits, or what did we achieve at the end of the day will be open to discussion and comments. So in the interest of time, I think everybody has said this. We should move forward. We feel uneasy when grappling with tough questions such as whether to cancel elective surgeries that are not immediately life-threatening but could result in more serious complications down the line. How about delaying timely repair of an acute rotator cuff in a young patient, which likely would impact the outcome? It can be hard to draw the line for what is critical, urgent, or non-urgent surgical care, and hence many questions remain unanswered. So when the pandemic broke up, we never closed our hospital, and whatever I will talk in the next 10 minutes will be my own hospital perspective and experience. So we never closed up, we never closed our emergency, and we never closed our clinics. So patients were coming in, they were thinned out, and as Sohail Saab has pointed out, we were significantly below his numbers. We were down to less than a quarter, even less than a quarter, in terms of both trauma surgery as well as elective surgery, if any. And elective surgery was less than 10% in April, May, and June. June has slightly picked up. So, but especially in April and May. But so the principle we applied, number one, was not to close the hospital and not to stop anyone coming inside the hospital or outpatient clinics where doctors would be available on their scheduled times. We did decrease the number of outpatient clinics that we do per week, every consultant. But the point I'm trying to emphasize is nobody sat at home and everybody was working, but to a much lower scale. So two interesting questions. These are directly cut, pasted, and copied from the literature. Will things will go back to, and I think they were touched by the previous speakers also. And let us skip that in the interest of time. Now, elective surgery in the new normal. As orthopedic surgeons, we should help develop sustainable institutional protocols allowing for the safe return of elective surgery and economic profitability to a healthcare institution and orthopedic. So I mentioned economics because, and I will show you a chart also, because ours is a private hospital. We earn what we generate. So the economics of my hospital is very different from a public sector hospital or any other hospital in Pakistan. So total joint arthroplasty represents a large portion of orthopedic revenue production due to high volume and high margins, and that is true for my hospital also. As we begin to make this transition, we need to understand that it will not be realistic to conduct the same case volumes as we were doing it before the outbreak. So we must first ensure the safety of our patients and surgical staff. We need to monitor the availability of supplies for the continued care of patients suffering from COVID-19. So this is where we embarked upon, even before safety of our patients, safety of our staff. And I will, in the end, take you through some measures that we did. As we resume elective orthopedic surgery and joint replacement, we must begin to reduce expenses also by renegotiating contracts of vendors and trying to use ambulatory and surgery, trying to do them in daycare settings, reducing hospital stay in a very safe and effective manner, adherence to strict evidence-based and COVID-19 adjusted practices, and incorporate, as mentioned by my previous speakers, telemedicine, other technology platforms when feasible for healthcare system. And I was also reviewing, there is an app of physiotherapy also. If our post-op patients tune onto that for different surgeries, they teach you how to do physiotherapy online while the patient sits at home. So there's no evidence in current literature to guide orthopedics services toward the progressive reintroduction of surgical activity. This is, I think, first time in our lifetime where our experiences are equal. So-called the West and East has matched finally in the pandemic. No experience in the West also, where we always look back upon to find some guidance and guidelines or practice guidelines. So everybody is evolving, every institution is evolving in their own direction, and so is, I think, WHO and CDC, the big guns that do exist. And obviously, they are making their guidelines in terms of the reality, whatever is coming to the surface. The main scientific societies leave decision-making to each individual center, and the existing guidelines are mainly oriented to activity during the pandemic peak period. Which, as I just mentioned earlier, and everybody mentioned that nobody knows how long is it going to continue. अच्छा ये एक chart है which I wanted to share again copied from an article, shows sustainable elective orthopedics, and the main theme was financial sustainability, which our hospital, being a private setup, is also striving for, because as I said, we earn what we generate. If we don't generate any revenue, then we don't earn, and so that's the kind of bottom line principle. So number one chart says patient demand for elective surgery. Number two is evidence-based practice on top of that. Number three is early discharge and orthopedic surgery. And then how can we bring technology and innovation into it? And then revisit contracts with vendors and government program. हमारे तो इतने stringent contract होते नहीं. But again, you see, if you come back to the first chart, assess post-crisis demand by asking patients who were canceled if they want to reschedule. Younger patients may not be able to take time off from work or may have insurance issues. Older patients may be reluctant to undergo surgery due to concerns. So hence, This table was able to provide some guidelines on how to kind of organize your elective orthopedic practice in terms of financial sustainability, which was our main concern also. So medical optimization in a COVID world with evidence-based practice was the next target. As we begin to resume, surgeons are now coming more to the operating theater. It will be imperative that orthopedic surgeons adhere to evidence-based medical optimization practices, which include local and federal recommendations regarding testing elective patients for COVID-19 exposure or immunity. Arthroplasty candidates with substantial risk factors before surgery need to be optimized to ensure high-quality outcomes while reducing resource expenditures. In addition, elective arthroplasty candidates with non-modifiable risk factors who may need ICU beds or multiple transfusions can easily be delayed if their community has increased COVID-19 demand. And that's probably where we stand out. Some of our very elderly patients with multiple comorbids, where anesthesia, stabilization, medical management would take a lot of time, they were postponed. Hospital systems may want to consider shifting elective orthopedic procedures to non-COVID or COVID light facilities for patient comfort. And I will take you through how we handle that and how we handle operating room issues. Early discharges, no comments about that. Patients are being, I would not say forced, but optimized to leave for home as early as possible. That's what we are all practicing here. So as early a discharge as possible. So patients not meeting the selection criteria for early discharge can instead be enrolled in rapid recovery programs at a regional hospital. That means a step-down hospital, if all is possible. Adherence to strict patient selection protocols will allow high-quality clinical outcomes while limiting complications and unnecessary expenditures and exposure. So even for a pre-op checkup, if elective elderly patient has to come to a hospital a few times to visit his cardiologist, to visit his endocrinologist, to get his sugars checked up, to get his heart checked up, and do a coronary stress testing, that would mean multiple exposures, and perhaps those can be avoided. So in a nutshell, these are our AKU surgery protocols, and these may be copyrighted, Nawasab. So I just have brought them here. So for elective cases, pre-op COVID testing, who test positive. So before that, every patient that would be operated at our hospital would have a COVID PCR done, swab, and you cannot get into the hospital without a COVID test done. So that was made mandatory, and we prepared a separate facility just outside in the parking lot to test all these people. So they come from just adjacent to the main road, they park there, they get their swabs done, and then go back home straight without entering into the main hospital campus. So we established that facility in the parking lot. And once they test negative or positive, then the course is taken. So this chart elaborates what would happen if they test positive. So our nurses would keep a track of them, whosoever patient, for example, let's take the patient of a possible candidate for knee replacement. If he tests positive, we need to inform. And then if they are positive and they can be delayed, they are divided into 3 categories. Category A, B, or C, as in shown in the chart here. Category A, we decided those who cannot be delayed for more than 2 weeks. For example, tumors, fast aggressive tumors with mass effects. The next was category B, which could be delayed for 14 days or more, like bypass surgery, or very slow growing tumors like for example, a meningioma or giant cell tumor of bone. Then category C would be the regular arthritic patients waiting for knee replacement. And then if the patient on top and on the first row, if cannot be delayed, he would proceed with surgery in the BDOR. That's our Bashir Dawood OR, the donor's name. We call it BDOR. And consultant and anesthetist would discuss. Appropriate counseling would be done between all three of them, the patient, surgeon, and the anesthetist. And then they would be subjected to immediate surgery if it cannot be delayed, and if they are positive for COVID. And I will take you through the rest of the protocol also. Now, if they are category A and they have no symptoms for at least 7 days, we proceed with surgery after appropriate counseling. If they are category B, they have no symptoms for at least 7 days, we repeat COVID. If it is negative, we proceed with surgery. If it is positive, we wait for another 7 days. And if it is category C, we proceed with surgery after they are negative. This algorithm we developed for all three types of surgeries. For elective surgery, wo jo abhi maine dikhaya, orange surgeries and red emergency surgeries. Red is, for example, an obstructed labor patient. In our setup, it would be a femur fracture with an arterial bleed, or a supracondylar fracture in a child with a obstructed brachial artery or a ruptured brachial artery. So that would constitute a red emergency which cannot wait. So these were protocols we developed for all three situations and have been following thereafter since they were developed. And obviously nurses are our partners in this, and they ensure that there is no breach in these protocols. Everybody kind of follows them, although it has been sometimes very inconvenient to test and wait for COVID test for 24 hours for example, an open tibia fracture, which would be an orange emergency requiring fixator debridement. But then the protocols were very strictly followed. Nurses developed these form, which is called patient under investigation tracking form. तो ये वो क्लिनिक में भर्ती हैं हमारे जो है सारी इंफॉर्मेशन लेती हैं about history, about travel in the number 2, and then if 1 and 2 positive will fill this bottom form also. तो उसको फिर वो ट्रैक करती हैं COVID status को, and they would let us know what is the final outcome. So this form was developed also, very new form developed in the last 3 months. Now every elective or emergency procedure patient उसका ये भरा जाता है. Excuse me. Now finally हमने क्या changes किए physically जो we thought would be in the best interest of managing COVID patients as well as managing non-COVID patients. So we had a 3-story building which was called the private ward, which was reserved for the more affluent people, and that we separated as a COVID ward. We labeled as COVID ward. We separated it for only COVID patients, where they would be, with that would they would go there after admission, screening भी वहीं होएगी, and then testing भी वहीं होएगी, and then they would be staying there if they are positive also. And then we created special negative pressure rooms over there, negative pressure ICUs over there, and brought our ventilators also on those respective floors, which we had 4 floors, so we had about 100 beds of a separate COVID ward where patients either suspected or COVID positive would go there. So, and then it has a separate entrance in the hospital and exit in the hospital. So those patients and even their attendants would not be mixing with the rest of the group. Now, next thing was operating rooms, which is our domain. And we separated dedicated 3 operating rooms and I will take you through that in the next slide. PPE, as Amr Bhai asked, I think were very essential. Hospital made extra efforts to procure them, and they were available in ample quantity. And the mask N95, the 3M respirator was given to everybody, every resident and every faculty who would go close to a patient, and to staff also who would go close to a patient. So employee health checkup, we established a dedicated app for our own employee health checkup. Those were free. And if you are having fever, you could enter into the app. I'm having fever. This is my employee number. And they would give you a call to ask further history, and then ask you to come for a test or just wait or self-quarantine or whatever pathways they had. So that app, everybody loves that app, and we can just enter and enter our symptoms, enter our family's symptoms also, and they would route us to wherever we stand as to the COVID status of our own self and our family. So the HR department allowed furloughs, and so we could take a leave, we could stay at home, and unpaid leave even for 6 months, and even for a year was allowed. HR rules were changed, and unpaid leave was allowed for both staff and faculty. So टेलीमेडिसिन, टेलीफार्मेसी, जैसे पहले भी कहा लोगों ने, वो सब पहले भी थी और अब और उसको स्ट्रेंथन कर दिया. One major thing we strengthened was home care services, which was the technicians, dedicated technicians and nurses would go home to take care of our post-op patients, and maybe establish a WhatsApp line from there, show us the wound, do the dressing, or do whatever care, or IV antibiotics, or whatever care they so desire and deserve would be provided to them. So this was significantly enhanced since last 3 months. And then home care vaccination was another thing. So lastly, what changes did we made in the operating room? So as we all know, operating room is a positive pressure aired room, and we have positive pressure coming air, ultra filtered air through the HEPA filters coming down from the top where the patient is centered, and then the air exits into the bottom on the sides through exhaust channels, and then hence it produces an air circuit in the operating room which is positively pressured, and it is ultra filtered to 99.99%. That is what constitutes a part of an integrated OR1, right? अच्छा, उसको फिर हमने 3 जो हमारे separate rooms थे, which were physically separate, also we converted the pressure to negative pressures. So that would mean that we would reverse the air circuit to gather from everybody and go up from the patient and exit from there. So in contrast to the positive pressure ventilation that we usually have. So we could do it only in 3 rooms which were physically separate. So hence it was easy to do as they were physically separate, and their air conditioning was also separate. And then we dedicated separate techs, we dedicated separate flow pathways for these patients, avoiding a physical mix, and enhanced PPE in the operating room. We had spacesuit type of things which would have antiviral shield, and would be provided especially to the anesthetist, anesthesia people introduce them here, and surgeons would use it on their choice. Otherwise, they would wear the respirator and the facial shield or goggles, depending on, again, their choice to operate on such a patient. So much so, thank you. So I think we now would open for a discussion. We are
sorry, can I take the lead?
If you want to start the discussion, sir.
Is that okay? Can I ask the first question?
Ji, bilkul, please go ahead.
So Sahil, our question is to you. Okay, so in our hospital,
Yes.
we had BOA guidelines to leave, most patients that could be managed non-operatively, such as ankle fractures and tibia fractures, and we did, right? But we had a terrible outcome because they all came back with really, really poor outcome, you know, and that is why we were operating on them in the past. But we were specifically guided to leave them alone. Is that something you have a similar experience or not like that? Because we were specifically
No, I'm afraid that, as I told you, that we had our priority lists. We made it in the beginning of this actually pandemic, I think in the start of April. And in our priority list, we had priority 2, which was actually urgent cases, and all intra-articular fractures were actually put in that category. So from us, the instructions were that it is preferable to operate upon intra-articular fractures within 48 hours. So I think that would actually lead to less kind of disabilities later on. So I felt that we should keep intra-articular fractures in urgent category so that we don't have to deal with disabilities later on. Of course, the results won't be that much if we delay this kind of surgery for a while. So for us, I think we have been lucky that we have operated on all intra-articular fractures, and in most of the centers. So we have 40 hospitals around, and all 40 hospitals, the same instructions were followed.
And what about the tibial fractures, the long bone tibia fractures?
No, tibial fractures we have all operated upon. We have not left them unless they could be managed conservatively. I mean, if we were able to manage them conservatively, then.
Sorry, Amir Bhai, your experience in that? So,
we can't listen to him. Probably he has to unmute.
Moving on then, yeah. Sorry, any more questions anybody wants to ask? Trauma first, yeah?
Right. Can I have my own experience of our own hospital?
Of course, sir.
Yeah. Actually, being a government hospital, so we did not have the liberty of refusing patients. Plus, because of the problem, because of this COVID, a lot of the private clinics were also closed, and in the periphery, the people were also so much afraid of operating in these circumstances that we got a lot of patients.
You've sent the unmute to the wrong Amir.
Okay, sorry.
The unmute message has gone to me, not to Amir Aziz Sab.
Okay.
This is the of having.
Sab wants to tell his experience, yeah? Right, Sab?
Sorry. You can hear me?
Yes, of course, sir.
Yes. So from March 20th to July 15th, we operated on about 970 patients. And we operated on all the patients who we thought needed surgery. And they included everything from fractured ankles, tibia fractures, femur fractures, fractured acetabulum. We also saw, in the start, we saw about 50 to 100 patients per day in our ENE as well. In the first couple of months, and after that, we saw around about 120 to 200 patients per day. So that's around about 9,000 patients we saw in our ENE during that period. As far as the patient assessment was concerned, actually, they were all risk assessed. The temperature was taken, and only in those patients where there was a clinical suspicion, the COVID test was done. We had about 4 patients who were COVID positive. The 2 patients elected not to be operated, so they went away. We did operate on 2 patients who were COVID positive, and both of them were DHSs. We did have, I will not say we have sufficient PPs, but we had enough PPs and we just made away with it. As far as the thing is concerned, despite operating on such a huge number of patients, only 3 or 4 doctors, 1 orderly and 1 dispenser became COVID positive during that period. But what we also did was that we tried to minimize the duty of the consultants and the TMOs. Our medical officers, we basically made them in batches, and all the TMOs, they would do duty 1 week and then they will be off for the next 2 weeks. The consultant will do a duty on alternate days. and we also had a WhatsApp group as well. So if there was some patient come in A&E, and if the trainee registrar would need some form of advice, then he will post it on our WhatsApp group, and we would give the opinion. Now, despite the fact that whatever is said, and being a government hospitals, I must say we got far more than our usual share of patients, 970 cases during this period, and about 9,000 patients. And God was very kind to us, because only 3 or 4 doctors, 1 orderly, and 1 of our dispenser became COVID positive, and they recovered without any problems. But this was our experience from the Khyber Teaching Hospital, Peshawar.
Mr. Saab?
Amir Saab is talking again, but he's again mute.
Okay, so any questions on trauma while anybody?
Yes, so can I
you hear me now? Can you hear me now?
Yes, yes.
All the talks were from the Army, the Hill Park Hospital, and AKU, private setups. We in the trust and government setups cannot say no at all. And we've just published a paper, hopefully we've submitted it to JBJS, of 1,500 cases. From March till 15th of July, we have operated on 2,200 major cases. We have done all trauma, including pelvic trauma, spine trauma, cauda-equina syndromes, tumors. We have done 100 joints, 200 DHS, and 70 bipolars. We did not do COVID in everyone. We did not HRCT in everyone. We screened them in detail on presentation about their travel history, their suspicious symptoms, and only those who were suspicious were sent for these tests. And we have a team of 200 people, anesthetists, 51 residents, 10 consultants, 37 nurses, 97 paramedical staff. And out of this lot, 30 became positive, and all of them recovered at home quarantine. We have 5 teams in the department, which we split. 1 professor, 1 assistant professor, and 10 residents, and a senior registrar did the OPD, ward round, and on call. So the rota was 1 and 5. And since I was the senior most and the 6th professor, I was there every single day. So I discussed earlier with Masood, and I think there's been a lot of unnecessary hype. The Italian paper of aerosol production, etc. We have been using all kinds of equipment. Yes, we did use PPEs, masks, visors. We also used hydroxychloroquine prophylaxis amongst all our team. Despite paradoxical reports from the WHO and CDC and Lancet and New England Journal of Medicine, we still followed that. And believe me, we cut down the number of people on duty. We did everything. We stopped doing scoliosis and regular elective surgeries. During this period, we've done 2,200. Normally, we would have done about 3,700 operations in this 3.5 months. I hope the Western journals accept our paper, because it has defied everything. There's a report from UK that the hip fracture infection rate went up to 20%. We had about 200 DHs, 70 bipolars. This was not our experience at all. And now we have also started doing scoliosis as well as elective joint surgeries. Yes, we are observing the protocols that are possible and not refusing anyone for these surgeries. So I don't know. The sports injury paper gave us the outlines, but no data. We have done 52 ACL reconstructions during this period, which is a significant number. About 100 elective joint replacements, 25 major pelvic fractures. So we have an experience across the board of both elective and emergency trauma. And Alhamdulillah, I have no reason to recommend anything otherwise. And there's absolutely no need for subjecting everyone who presents to a COVID or an HRCT unless they have suspicious symptoms. And then what we've done, we've operated most within 24 to 48 hours. We have 10 operating rooms dedicated to orthopedics. 2 were separated for suspicious COVID patients. Rest were functional 24/7. So Alhamdulillah, the worst thing is that most of the teaching hospital in my city were refusing even vascular injuries, dislocated joints, intra-articular fractures. My brothers in KPK have done a wonderful job, but I cannot say the same for my city, Lahore. I don't know what the state of affairs is in Karachi, but I think POA should be more proactive and send guidelines to all its members. We've had people who have clamped down and closed the wards when only one person became positive out of the team. So I think we need to rethink, and a lot of things are possible. And I personally feel that there's been an overhype and we've been paranoid. We've not been realistic. And I still feel with adequate precautions, we can still resume full activity. All our outpatients of follow-up were done. Elective new outpatients were reduced to 1-3 voluntarily. We have 170 trainees spread across all major cities of the country, and all people coming from outside were sent to them for follow-up. We have telemedicine since a few years now, and we resumed that most actively. So my request is we should sit together and devise our own protocols, evidence-based, not what says. In this time, I have called WHO the World Hoax Organization and CDC as completely diabolical situation categorizing, and they've gone back 180 degrees of what they recommended initially and then again. So let's make up our own protocol based on our own experience. And you're all welcome to double check the experience, whether we are lying or we're exaggerating. It's all for everyone to see, but we have no reason to lock down and do these fancy testing in everyone.
Professor Amir, can I ask you a question, please?
Yes, please.
So you were actually operating like you were operating before. There was hardly any difference. So number of
60% number.
So it was a huge number. I mean, 60% of the capacity of the normal. So did any of the patients develop COVID-19?
Only 2 or 3, none others.
No. Have you actually gone through your data, and are these figures? I mean, are these the
yes,
correct figures, or it's just an assumption?
No, we have analyzed 1,500 of our patients, which we have written and submitted to JBJS. We have done 2,200 by now, but 1,500, we have a follow-up of more than 3 weeks.
And out of these, only 3, you say, have developed COVID?
Yes.
Okay, fine. Thank you.
Munawir, can I comment?
Yeah, sure, Arif, go ahead, yeah.
Okay, so would like to share our experience. Our hospital is the main hospital catering COVID patients even today in KPK. We received the maximum number, so much so that the orthopedic ward has been taken from us and has been made the COVID ward, and we are sharing our facilities with the ophthalmology department for inpatients. Having said so, we have never changed the indications for our surgery during all these periods. So whatever we were operating before, we were still operating, with the only exception that the elective cases were stopped, and they were because of the government orders. To begin with, we were all scared, and we were doing a lot of precautions and having those suits and N95 masks for everybody. And so many other things, which probably later we found that they were not very much necessary. And during this time, now we have limited our precautions to very few only. So we are using normal gowns. We are not using any special gowns. We are using N95 or KN95, which is not N95 mask. And sometimes we use double surgical masks. And we are using eye shields or goggles. These are the only precautions that we are taking, and we have made it mandatory that all the unnecessary personnel should be out of the theater during intubation and extubation of the patient. The rest, we are all continuing. And I cannot say that we have not been infected. The other day, when I was operating, and I just inquired from the operating theater staff how many had the infection. There were 12 people, and 8 had already had the infection, which were documented. And 4, including myself, we were still not infected. But all of them, alhamdulillah, recovered. None of them had serious infection. Our about 7 residents had infection, but everybody recovered. The father of one of our residents had died. This is the most serious thing that happened. But the rest, alhamdulillah, everybody has recovered. So coming back to the what Amir Saab said, that probably a lot of things that we have been doing were not necessary. And maybe during the next couple of weeks, we might be in a position to restart the normal electoral procedures as well. But for that, we will need the government orders. But as far as technically we are concerned, now the fear that we had is no more there, and the people are now using fewer precautions as they used to have, but the mandatory precautions are still there. And alhamdulillah, we have done well so far. So I think I will add to what Amir Saab said, that a lot of things that we have been seeing and a lot of things that have been done were probably not necessary. And we were having unnecessary scares and fears that we had. Probably we can do much better with fewer precautions.
We started our day with Bismillahillazi la yudurru masmai shay'un fil ardi wala fis samai wa huwa as-sami'ul alim. And after that, we just cracked on.
Ahmed, you want to have you still mute, you know? You need to unmute yourself.
No, sir. Can I say something?
Yeah, okay. Let Amir say first, and then you can come in afterwards. Yeah, Amir's been trying to put his hand up for a long time now.
Assalamu alaikum. I just wanted to almost reverse the roles. The UK is one of the worst performing developed countries in terms of COVID. And I personally got COVID in the first week because we didn't have PPE, and I nearly died. My SATs were well lower than 87%. Took me 6 weeks to recover. So I've personally been affected by COVID. I know how severe it is. So what is Pakistan doing better than the UK? Is it a different population? Is it to do with the immune system? Is it different variant? What are we doing wrong in the UK that Pakistan is getting right? That's just a open question to everyone, really.
Amir, both my sons were positive, and alhamdulillah, they recovered. My sister, who's the head of anesthesia, became positive. She's also recovered. Nobody knows the answer to your question. Maybe because we pray hard and rely on Allah, He helps us. I have no scientific answer.
Because hopefully I do the same. And certainly my family had it. So it's just, listening to all the talks, I know, I said in the questions, so this is for my own learning as well. Number one, we've had huge PPE issues, and none of you guys have mentioned PPE issues, which means they mustn't have been. I do know my colleague's mother-in-law who got refused with a fractured neck of femur in around the Gujranwala area, multiple hospitals. Then she went off to Islamabad. They were refused treatment, and so that's from personal experience. And the other thing is, do you have any special precautions in outpatients and when you're seeing patients in wards? Because I'm absolutely amazed at how little effect COVID has had in Pakistan. It's just really revealing.
Amir, can I reply to you?
Yeah.
Yes.
But Amir said that there is a high mortality in UK on the doctor side with people who are black, which is a bad word to use, Asians, and people of minor ethnicity, very high compared to everybody else. Now, I don't know what the reason for that is also, but you know, it is real, it's true. And we were doing what we were told by the government, so we didn't do anything different. We were given plans, and the BOA was very active, and it every 24 to 48 hours, even you know, would give us guidelines what to do and how to follow it. So for us, as Amir says, it's a very real thing. Alhamdulillah, I didn't get the COVID, but I was not away from the hospital like Amir Aziz. I was working 24/7 for 21 days, continuous. You know, and my wife told me not to come to the house. She'd make me shower, and she used that temperature guard, and she used to check my temperature before I used to come into the house. You know, it is something that Allah gave me the opportunity to help. But it is real. It is real. You know, this COVID thing is real. We cannot say it's not real, and we have to have a plan. Fortunately, it's passing us now. But you guys are in the epicenter now by the looks of all the stats that are coming from Pakistan, although it is not as difficult and severe. But yeah, I mean, sorry about that, Zaid Saab, you can now continue, yeah, because I just want to say something that it is real for us anyway here. For us, it's very real.
Just going to make a couple of comments. Obviously, we are listening to different viewpoints. And similarly, in UK, we will have different viewpoints. We will have different viewpoints from different people. So there will be very cautious viewpoint, and there will be very liberal viewpoint in terms of how we deal with the things. But we must stick with the accurate data. So all the 3-4 participants from UK, in March, April, we saw that our ITU got filled up. So our anesthetists were busy. So the surgeons can't operate, obviously, if your anesthetists are all tied up in ITU. And it was very obvious that we are going to do something because our ITU beds were full. And similarly, in March, April, when the wave came, we started to see that our wards were getting full, and some of the patients who were COVID negative after second, third day in hospital or after 5 days in hospital became positive. So there was something in the air, and coming to hospital was dangerous. So I think what we need to learn is that there is enough evidence to say that the COVID-19 has produced significant devastation in Western world. In my view, Western world data recording is much better. In UK, we saw the peak in the first few months in March, April, when we were probably not prepared. Luckily, I think in Pakistan, the virus came later. So there was some experience gained from the Western world where, you know, there were some protocols were already established and you were able to deal with it. In my view, there's no doubt, I think the virus seems to be less virulent in Pakistan, which Pakistanis should feel lucky about it and thankful to the God or all the prayers the people who are there do it. But currently in UK, our private hospitals are owned by the National Health Service. So we won't be able to operate on any joint replacements unless there is a national consensus. And in my view, it is always better to have consensus because there will be different viewpoints. So you have to work as a team and have a combined consensus. So then you bring something somewhere in the middle of the table. So you don't have very extreme view at one point and a very extreme view at the other point. My advice is that there is a need for consensus even in Pakistan because the setups are very different and very different variation, a lot of variation in government hospital, military hospital, and a lot of funding issues for doing too many COVID tests. So there should be some sort of guidance which will be helpful for the people of Pakistan as a consensus.
Okay, I'll ask Shahid because a lot of people are talking about joints and arthroplasty. It's his main stay of arthroplasty, as Arif Saab is doing and as Amir Aziz is. But let's get Shahid in. But before Shahid comes, I'll make a comment.
Thank you very much for, yeah. I'll just give you 2 comments and then I'll talk about joint replacement. Alhamdulillah, we have been very Allah has been very kind to Pakistan, and we don't know what is the reason of this being that we are not affected so severely. It might be that the virus is of low virulence, it might be the weather, it might be the immunity. But whatever, the infrastructure of Pakistan, everybody knows that it is very weak. But I'm just going to talk about the positive aspect. Suhail Amin has said about telemedicine and telepharmacy. But then I'm just going to spend 2 minutes on an entirely different aspect. We have been importing everything from a needle and a syringe to everything from abroad. And this has been putting a lot of constraint on the health resource because we were spending a lot of foreign currency. And now the positive aspect is that in addition to producing atomic bomb, and in addition to producing high-speed jet aircraft that we have down Indian airplane, now we are able to produce ventilators. On a similar ground, I think this practice should be promoted. That one of my anesthetists said that 30 years ago, he was able to manufacture anesthesia machine in his home. So in ICU, you require a ventilator, you require monitor and oxygen. And if you're able to produce all these things in Pakistan, then we can significantly reduce the cost of treatment for population. Number two, we will be producing industry, which will occupy a lot of employment. And then in future, we will be able to export. So we should be able to manufacture. I would address Suhail Amin that the army has the resources and infrastructure. That image intensifier is a very common thing. Imported image intensifier will cost 1 crore rupiah ya 1.5 crore rupiah. We should be able to produce it for 10 lakh rupees, 15 lakh rupees, 20 lakh rupees. So every orthopedic surgeon in Pakistan should be able to have access to a low cost machine. We should produce power tool. एक अच्छा power tool जो ना 25 से 30 लाख रुपए का आता है. So we should be able to produce power tool, image intensifier, and every other thing. So we'll be able to save foreign currency. We'll be able to export. We will reduce the cost. Now coming to Munawar Shah, at Liaquat National Hospital, we were open 24 hours. We never stopped working. So emergency department was open. We had the policy and SOPs for COVID. We had a separate department and investigation. So we did all trauma surgery after taking precaution. The elective surgeries were stopped. Recently, in the month of June, the hospital decided to open elective surgery. So we had been doing elective surgery, including joint, after screening all patients for COVID. So we should make a point. This webinar is very good, but we should learn from the experience, as Amir Aziz Saab has said, Zahid Askar Saab has said, and Suhail Amin Saab has said. But I think there should be a definite documentation of at the government level and at army level that this should be priority. This COVID is inshallah going to finish, but we should not be importing anything. We should be at least be able to produce a Mehran and simple. We are not asking to produce Mercedes and BMW. Alto to bana lena. Alto जो है ये मरी भी चली जाएगी, स्वाद भी चली जाएगी, खंजराब भी चली जाएगी, काबुल भी चली जाएगी. तो ऑल्टो लेवल की चीजें जो है वो पाकिस्तान में बननी चाहिए.
Okay. Thank you, Shahid. I just wanted to do an open question to all of you guys. So the experience from China during COVID times, negative patients, when they were operated, they had over 40% of morbidity and 25% of mortality. Now, this is an anecdotal with no evidence statement that I'm making, that I saw a lot of Facebook pictures of everybody wearing 5 masks and you know, the Ghostbuster kit and continually doing private operation and surgeries in private hospitals, including sports injuries, and they were advertising it very proudly that I'm doing this. Now, what precautions are you guys were taking? Because in our part of the world, all plant surgery was closed. Now we're opening up, but what we are doing is we have green hospitals and green corridors, which means that hospitals that are COVID negative are getting patients. They get 2 weeks to self-isolate, and they have to have a test before they come in at 2 weeks and then 3 days before surgery. So was that all done in Pakistan, or like Amr Aziz Saab said, you know, Allah Ta'ala ne jo hai, sabko protect kiya tha. What is the state of affair of that? Because I will then ask Rehan also to comment on his Irish experience and see what he thinks about it. And Farid Saab is there. Maybe he can tell us something about his experience. But all of you, this is a general question to all of you. So,
most of our team had this 3M respirator available, and every team will have an N95 mask. So we purchased this mask and gave it to all our team members. So during OPD, all of us wear this, and during surgery, we wear this. So we take precaution, but then we are starting to do everything completely. We don't know. Everybody is learning. The developed country in North America, in Europe, and in Asian countries, we are learning. So it's a new disease. Initially, we thought that it is a respiratory disease. Now it is a coagulopathy. Now is it a cardiovascular problem? People are saying about the neurological problem. So it's an unknown enemy. So we have to take precaution. Taking extra precaution is not a fault. A lot of people have died. I mean, and senior people. There's Somro Saab, Khalik Siddiqui Saab, Mustafa Kamal from Multan. So taking extra precaution is no harm. Once we have learned, we can reduce the level. I mean, it's like a war with India. Take maximum precaution that you can take. Once you know the strength of your enemy, you can reduce the level of your preparedness. But you cannot take any chances. This is mild cases in some, and somewhere it is lethal. We don't know. So just take precaution.
Okay, thank you. Rehan,
can I answer to your question, Munawar? Your question of having more complications in COVID positive. So we had few patients who came in emergency, and they submitted their samples, and the result would usually take 3 to 4 days. And during that, we operated on them, and later on, the result came positive. But in none of these patients, we saw any complication which would normally not be there. None of them developed actually any serious complication. It was just normal post-op recovery. So that study, which showed that very high mortality rate and COVID positive, in these few patients, we did not see. These patients are probably 4 or 5, not much, but this was our experience. I would like to share one study that we are right now in the process of writing. As I said, our hospital was the main hospital that is still catering the COVID patients. So we had 148 people who died from the COVID infection during this time. And while compiling their statistics, there was one strange finding that 97 out of them were A positive group. The next common was B positive group. And when we did some statistics, we realized that A positive group, they were 7 times more prone to go toward the mortality as compared to O positive group. And B positive were 3.5 times more toward the mortality as compared to O positive. O positive or O negative had the least complications. I don't know how important this, how significant this finding is, but this is one of the main findings that is coming out of our study.
So the most significant finding is I am not A positive or B positive. Sorry.
शाहिद नूर ने जिन बुजुर्गों के नाम लिए हैं, अल्लाह उन्हें गरीब की रहमत करे, none of them was actively treating orthopedic COVID or non-COVID patients. So they became positive in isolation. So this argument is plus minus, and we take precautions which are possible, but no overkills.
Now, in our country, in UK, most of the patients that are passing away or dying from COVID are in the nursing homes. So they're not treating patients, but they're dying because, well, apparently there is a paper or a legal paper that's been created for those guys that they are suing the government now for not telling them all the information. But that's Rehan, your experience from
Thank you for the invite. Ireland has been lucky enough. We didn't have huge numbers. We had around 1,700 people died, mainly elderlies with multiple comorbidities. The experience with Cork, we have orthopedic service in 2 hospitals. One is pure elective, other is trauma. So we have to close our elective service down for a few weeks till we know what exactly happening. We moved the trauma service partly to the elective unit, and they were walking in trauma, so wrist fractures, ankle fractures, kids, and kept the major trauma on one side, so we didn't stop operating on emergencies. So everything was done. We are very lucky to have a lot of periprosthetic fractures. So in a week, we would do 3 periprosthetic fractures every week. So revisions were done, primaries were done for hip fractures, not for elective stuff. So far, we've been lucky. We don't have any complication like that Lancet paper was talking about, 20% mortality. So I had one of my own patient died after a fractured neck of the femur, had a total hip, had a PE, massive PE within 48 hours. So that's one mortality that we had. No increased risk of infections. We are almost 6 weeks now back to elective services. So we are at full speed ahead, and the numbers we do, we are back to those numbers. So we have no major issues with it. PPE was there. We initially, for 2 weeks, we used the PPEs as we were advised by the infectious disease peoples. But after that, everybody was tested COVID. Everybody was in the house, so they were quarantined anyway. So we didn't took any major issues unless there was somebody positive. So alhamdulillah, so far so good. We haven't been bad. We are back to almost full capacity service. The government in this country nationalized the private hospitals as well, so we can have more beds available to us. So still they're keeping that 40% capacity in case there's a second wave. So far the country has been free of COVID, except once we have started opening the borders. So there are a lot of flights coming over from Texas, and the infection rate has gone up. So they're looking into closing the borders back again at some stage. And we are still in the lockdown. So there are 4 phases of lockdown. So country is still not fully open yet. So I think the overall experience is same. And as every speaker said, we are learning as we go on along. But I think that the risk of community COVID in this country is not too high. So I think we've been lucky compared to UK, which has fairly high community acquired COVID.
So just to share one of our experience, we have done 79 neck of femurs during the start of the COVID times. We have tested everybody very rigorously, and we have ended up with at least 9 or 10 patients who have become positive when they were negative to begin with. Is that experience anywhere in Pakistan where you have negative patients who were operated in the hospital and they ended up positive?
Can I answer this question, please?
Yes, of course, bye.
Yeah, so the data that I presented in our setup, so out of 225 surgeries that we did initially in COVID negative patients, out of these 5 tested positive later on. So it's around, I would say, like
similar experience,
yeah, 1% conversion, I would say. So this is our experience over here. And from our team of orthopedic, all staff, including, we have around 50 members, consultants, trainees, and staff in our setup. And out of these, those who tested positive are 7. So we had a lot of exposure, but of the staff members developed disease to an extent that it was serious. So all had symptoms, but all were limited. And then all of them actually became COVID negative later on. But this is what...
So there are cases of false negative test as well. So there could be, I mean, positive PCR is a positive thing, but if you have a negative PCR, it could be a false negative. Patient have been infected in your hospital, or they were PCR negative, but they had mild COVID, and they
mild or asymptomatic maybe. Yeah.
Asymptomatic.
Yeah. So Munawar Shah, I think the difference is that in UK, once you do an elective surgery, now you've started, you do a 2 weeks home quarantine, isn't it? Home isolation. That is the standard practice, you see.
So we were
And those 2 weeks of
in green hospitals.
yeah, in green hospitals, that means COVID negative, isn't it? It's the pathway that is totally COVID negative.
Yes.
So in our case, we found out that since you see, we were operating, of course, in emergency setup, and all urgent cases were being done. So we did not have the luxury to actually isolate the patients. So we just resorted upon just testing them once COVID PCR and doing HRCT along with that. So I think that also makes a difference, because people can be in incubation period once you actually operate upon them, and then
Yes, correct.
so that is one factor that makes a difference.
But does that make a difference? It doesn't make a difference at all. So why spend so much money in HRCT and COVID to make a difference in the results?
No, it can make a difference. You see, we were lucky that all those converted 5 actually survived. One of them went to a ventilator as well. You see, it makes a difference.
So all of you guys,
it does not justify the huge expense.
Yeah.
No,
you can do it in suspected patients.
Yeah.
See, there is a difference between making a policy. We actually work in an institution where there are policies and SOPs. So if we made this policy, it was for the safety of both staff and for the patients as well. And we actually worked upon them, and I think we have done a marvelous job in the sense any one of our staff members and the patients as well that we operated upon.
7 of your staff out of 50 became positive despite this great policy. 200 में से हमारे 30 positive हुए, which is overkill. So how do we justify this overkill?
No, but you are trying to justify it retrospectively, you see. Had any one of them died, the figures would have been different. So you know, now you are actually analyzing your data retrospectively. So we had to take lead from others' data.
There is no evidence to date which states that you must do it, and
So in our part of the world, one life is worth everything as much as Pakistan is. We need to make sure that one life is not lost. I'm going to ask a very controversial question. I'm going to bring this meeting to close, because I think we all have various views and it's never going to end up. My question is there or ever an opportunity for the private practice to be owned by the government as we have in the UK? So everything is now the government place. We are making capacity, and we are using the private hospitals as green hospitals, which means that all planned surgeries will start there. It is not going to be private practice. It is going to be NHS patients being operated there. Is there anything you see in the foreseeable future to help the National Health Service, as you have in Pakistan, equivalent, for the private sector to pull in? No answer. Okay.
Yes, Suhail.
Yes, I just wanted to tell you that now, since we actually converted one center, now the numbers have significantly dropped, and we have around 100 patients right now. Say they rose to around 1,200 patients in the peak days. Now they are, and we have been given a date that after around 1st August, we are going to actually reshift our setup from to MH, so or back to MH. And once that is done, probably we are going to be given the signal to start our electives, and that will be around August or mid-August that we are going to start our electives with. But as you have the green path, that kind of course, luxury we don't enjoy. So we have to.
Question, it was a tricky question. The reason I asked is we have green hospitals and green pathways because our private hospitals were closed completely, right? So then the NHS took over, and we've now moved in. I don't think so. Something like that exists in Pakistan because nothing was closed, and apparently you don't have green hospitals or green pathways. And
no, we don't have. We don't have any green.
Okay, so I'm going to
private hospitals have been operating independently, so they were not actually under central control.
I'm going to close this now.
Can I say something?
Munawwar in KP, develop COVID hospitals. But that idea failed for the reason that those places which were designated, supposed to be designated for COVID, they had, example, if a patient having an orthopedic trauma or having a cardiac issue comes who is COVID positive, if he goes to that facility, he will not receive the treatment as well. So they would be mismanaged. So for that reason, that idea was dropped and every hospital developed their own COVID facilities so that the patient has diseases they can be treated.
So that idea came from England because we made Notting Hill hospitals with a capacity which was completely over the moon. And apparently we spent billions of pounds on it, but we've not used them. We have 5 facilities in the whole of UK, but none has been used purely because I think the pandemic finished by the time we use it. So last question for Amir, and then we should call it a day because it's gone too long now, yeah?
Can I just clarify from Professor Amir Z? All your patients tested for COVID, or do you selectively test?
Amir, we do not test them as a routine. We have a thorough questionnaire in the beginning. If they have any suspicious symptoms, only then they are tested. Otherwise, they're not tested as a routine.
So those people that, alhamdulillah, then, and in Pakistan, then again, I know again from personal family experience, people don't want to say about symptoms because you have such a good track and trace positive test. Everyone there's a government official at their house and locks everyone down. So people are scared, and even my relatives that are very high up and have not gone for tests because they're scared of the government officials taking them to hospital or locking them down. So how do we know the prevalence? And this is across to all the rest of institutions and private institutions. If every patient is not tested, how do we know the prevalence in your population?
I mean, we were testing every patient for with PCR. All the patients, they were all trauma or emergency patients. And during, we had 8 or 10 patients on the list, about 30 to 40% of them would be asymptomatic positive. So that's why we make it mandatory for all of them that they should be coming asymptomatic positive. What would be the significance on the overall prevalence? I don't know, but this much I can say that there were a lot of people who actually were positive. They were asymptomatic, probably have missed because we have not been doing the PCRs.
All our patients used to have a chest X-ray after a thorough examination, because in majority of the COVID afflicted patients, the white count tends to fall, although not in everyone. And the private labs that were doing the COVID test here, negative rate of 35%. And the cost was 9,000 rupees per test. So unless it was absolutely mandatory and patients had a lot of symptoms, only then they would HRCT as well.
So in our country, everything was free. हम लोग मुसलमानों से ज़्यादा मुसलमान थे. Sorry, very sorry, but everything is free in our part of the world and has been since COVID times, and they've created.
No, but in our hospital, free, and since our own hospital was doing it, the patient was not being charged.
Okay, Masood bhai, can you please conclude so we can call it, because my wife's banging on the door now and she wants me to do something for her.
So just one thing. I left my house one day thinking I may never see my kids again. So that's why a personal interest in this. So inshallah, may you all keep healthy, but just in case we do with our strain, all I can please say is look after yourself and your families. It's just, it is a horrible disease to have. And
you are not allowed in Pakistan, Amir.
Pardon? I'm going to come and work
For
in
at
Professor
least 6 months.
You are already immune. Amir, you can come anytime.
No,
I've got a
immunity
pass.
is also very deceptive, you see. In this,
If you're immune, it doesn't mean you can't.
there is no immunity actually.
Can you call it a
He's up.
Ji. Thank you very much, Dr. Sohail Amin, Dr. Khalid Shah, and all the panelists, Munawar Bhai, for arranging such a and guiding us through the various questions and hot topics that do exist. So you see, at the end of the day, there is still controversy, and people have their huge wealth of personal experience published also. So I think once we have those publications coming out from Pakistan, from these respectable institutions, that would be of a great value. And if they're journals, big journals, so that would highlight our issues and highlight how we manage this pandemic. हमारा issue हमारे hospital में बहुत छोटा है, लेकिन I think आमिर साहब, आरिफ personnel, Sohail साहब have done a huge and wonderful job to manage this, organize it at their homes as they would individually without and taking guidance from international. So I am waiting very eagerly for this data to come out in indexed journals, and I think Pakistan people would learn so as to say that how we manage so successfully thousands of surgeries without getting significantly affecting our staff. And one thing jo sub paper mangenge, I think, which you touched upon, is the post-op course. There are papers now coming up of 2 months follow-up, 3 months follow-up with morbidity, but I think papers and journals would ask for that. But anyhow, to conclude, I think a very, very rich discussion. Thank you everybody for joining in today on a week end, mid commitments, family commitments. But Munawar Saab, thank you for taking the lead, and you had some pressures. I can understand, but you took those pressures. I also took some pressure.
There is no pressure.
In the interest of knowledge and education and science.
Absolutely.
So thank you very much.
So just to make one comment, I finish this off. Our Levi said to me once, long time ago, evidence before evidence. And I think I still hold that. We are all talking lots, but inshallah, Pakistan will publish, and then we will have, evidence-based talks after this anyway. But thank you very much for all of you. I will put a video of it, and I'll give it to Mr. Dumar Saab and Keshav, Khalid Shah Saab, and hopefully they will distribute it if anybody wants it. Thank you very much.
Thank you.
Please stay safe and look after yourself and your family.
Thank you.
Allah Hafiz, everyone.